We're going to go ahead and start. I want to thank the both of you for coming. I know y'all are busy. You're from Centera Albemarle Medical Center, so I know you're very busy, and I appreciate you taking the time to come and talk to all of us about breast cancer. It's something that's very important out there, especially in October. It's a big thing. Bailey, I want to go ahead and say thank you to you. Bailey works in the office sometimes with them, and she was able to give me the phone number to call both of them and set this up. So Bailey, thank you very much for helping Miss D get this together.
Hey, Bailey.
Hey, Bailey. So we're going to go ahead and start. If you'd like to introduce both of yourselves, and then we can jump right into it if you'd start talking about breast cancer, please.
Sure.
Thank you.
I'll kind of go first. Oops, sorry. Can you all hear me okay in the mask?
Yes, ma'am.
Okay. My name is Kira Matthews, and I am Volunteer Guest Services Coordinator here at Centera Albemarle Medical Center. To give you a little bit of background on my cancer, I am the survivor in this little group here. I actually took my job in June of 2018, and in July of 2018, I was diagnosed with an aggressive form of breast cancer, and it was called triple negative. And throughout that, I had a double mastectomy. I had about 4 months of chemo and 3 surgeries. Leslie was my patient navigator. So Leslie was there from the time it hit till even now. So, you know, I'm still trying to, I'm 2 years out, still trying to, you know, still surviving. So doing well. And, you know, there's lots of things out there for survivors. So if anybody has any questions about, you know, what you do after or how it felt during, please feel free to ask, because I'm happy to share any part of it with you that you'd like.
Yeah. First of all, thank you for having us here. We particularly in the month of October like to discuss breast cancer, but honestly throughout the whole year, it should be discussed. So my name is Leslie Scott. I am the hospital's oncology nurse navigator. I have been a registered nurse for 26 years. I have been doing oncology for 19 of those 26. So my role here is, as soon as you're diagnosed with cancer, I mean, you're thrown into a whirlwind. You feel like you're in 5th gear. We are sending you to this test, to that test, to this doctor, to that doctor. And it just becomes like you're on a roller coaster. So my role is primarily, like Kieran said, I'm with you from the very beginning, from time of diagnosis, all the way through survivorship. I am provide you education. We go over particular barriers. If there's any assistance that you might need, whether it's transportation, financial assistance, and lots of times it's just simply just there to talk. You know, sometimes you just need to talk and kind of talk things through. Breast cancer is honestly the most cancer that I see and deal with the most. I cover all the cancers, but breast cancer is the primary one. Breast cancer actually is the #1 cancer diagnosed for women, and it's the 2nd leading cause of death for women. 1 in 8 women in the United States will have a chance of getting breast cancer in their lifetime. Every 3 minutes, someone is diagnosed with breast cancer. Every 12, someone dies. So if we're on this call for an hour, that would mean that 20 people will be diagnosed with breast cancer and 5 will have died from it. So I mean, those are you know, numbers that should get your attention. The good thing is that the incident rates have actually increased over the years, but the mortality, the death rates have gone down. What that means is that more breast cancers are being diagnosed, however, more people are surviving and living. Part of that goes because the technology has just grown as far as detecting them. And then also the treatments itself has just advanced so that we're able to, people live longer. There are over 14 million women that are walking around living productive lives that have been diagnosed with breast cancer. important thing is early detection. We talk about early detection. I mean, it is the best weapon that we can have. It is, honestly, it saves lives. When we talk about early detection, one of the primary things that women can do are self-breast exams. And that is something that over the years has kind of changed a little bit. And as far as the, how we discuss it, you do those, we don't say so much of a breast self-exam as just an awareness, because you want to be able to know, be familiar with your breasts. They want to know, what it looks like. What does it feel like? When you're doing those breast self-exams, we typically say you use your 3 fingers here and you use the fat pads of them, and you lie down and you simply go in a circular motion, and you want to do it at different depths. You want to do it very lightly, and then you also want to go a little deeper when you're doing it. Some people can actually go almost as if you're like mowing the grass and do it in rows, whatever's more comfortable for you. The next biggest thing is mammograms. Mammograms, the ones we have now here at SAMC, are what we call 3D mammograms, and they actually detect breast cancer 41% more and earlier. They just is, imagine, when we talk about a 3D movie, how it projects on the screen, very similar to that. The radiologists are able just to detect them a lot earlier. It was estimated that if a third of the deaths could have been prevented if they had the patients had done early detection through mammograms. A third of them could have, because 71% of the breast cancer deaths occur because they didn't get their screening mammo, which is just something very simple that we can do. There are risks. People always talk about, what are your risk factors? The greatest risk factor, believe it or not, is female. Now, breast cancer can be diagnosed in male or female, but it's typically in your female. If you have what we call a first-degree relative, and when we talk about a first-degree relative, that is you have your parent, a sibling, or a child that has breast cancer. If one of them have breast cancer, it increases your risk by 2 to 3%. I mean, 2 to 3 times more likely that you'll get breast cancer if you have a first-degree relative. If you have had your first child after the age of 30, or if you have no children, it puts you at an increased risk. Actually, if you are a female who started their menstrual cycle before age of 12, you're at an increased risk. If you went through menopause after the age of 50, that puts you at an increased risk. And especially if you have a personal history of ovarian cancer, it puts you at an increased risk for breast cancer. Alcohol intake, believe it or not, can slightly increase your risk. If you have 1 drink a day, you are 7 to 10% more likely than a non-drinker to get breast cancer. If you have 2 to 3 drinks a day compared to a non-drinker, your risk is 20% higher. Being obese, especially after menopause, can increase it. Smoking. Now, smoking is just, I'm also the lung cancer navigator and screener here. So if you're smoking, I'm telling you, don't smoke. It's not good. It not only does it do breast cancer, but I mean, it can a number of cancers. And actually, if you are a smoker, your chance of dying from breast cancer is 25% higher. So I strongly do not recommend that. Like I said, being overweight, no exercise, those are also put you at an increased risk for it. A lot of people talk about the BRCA gene. Actually, there's only 7 to 10% of patients that get diagnosed with breast cancer actually carry that gene. 75% of the women that get diagnosed do not have a family history of it whatsoever.
I didn't have a family history.
Yeah. Most of them don't. But in that 7 to 10% that do, if you have that, if you carry that BRCA gene, it's a gene mutation, if you inherit it, and you can inherit from both either your mother or your father, if you inherit it, you have a 56 to 87% chance of developing breast cancer by the age of 70. So if you do have it, your chances are extremely high that you're going to end up developing it before the age of 70. But there again, most of them do not, most of the patients don't have that family history. Let's see, what else do you need to know? Or you have any questions so far? Because I'm throwing a lot of information at you.
If you do have any questions, we have Adrian, Mr. Adrian. If you can put it in the chat and he will call on you for your questions.
Bailey has a question.
Okay, Bailey.
And then in the coming years, do you believe that the number will increase or decrease of the breast cancer cases?
Great question. So I do think, because that's what we've seen over the years, I mean, technology in medicine, it's a constant state of change. I mean, we're constantly, things are just improving. So as technology improves, I think you'll see the numbers go up because we're able to detect them earlier. But with that being said, I think more people, even though diagnosed with it, I think they'll live longer because of the treatments that we can offer them.
And also within the next couple of years, do you think we'll find any new strands of breast cancer?
Another great question. So a lot of people think that breast cancer is just, when they talk about it, it's just breast cancer. There are over 15 different kinds of breast cancer. There are a number of things that we look at when someone's diagnosed with it. The pathologist, which is, we go in, we get a biopsy. So anytime they come in for a screening mammogram, if they determine that there's something suspicious on it, then we bring them in for a biopsy. Centera's goal is that from the time of that screening mammogram to the time that you get that biopsy is in 8 days or less. The goal is we do not want women sitting there worrying and being anxious about it. So we try to get you in from the time of that screening mammogram to biopsy within 8 days. When they do that, they go in, they take just little pieces of it, and we send that off to a doctor called a pathologist. That doctor looks at it underneath the microscope. And what he does is he's looking for a number of things. We look at the size of it. We look at how it behaves. The best way to describe it is, they compare it to your other cells. And just like kids and people in general, you have some that behave well, some that behave poorly, and that some that are kind of in the middle there. When the pathologist looks at it, he's going to give it a score based on that. When they look at all that, that determines your treatment. So where Karen's cancer was a very advanced cancer, and she talks about it was a triple negative, one of the things they look at is we look to see if there's particular hormones in it. You'll hear us talk about estrogen and progesterone and this HER2. The ones that are all three negative actually have a tendency to be a much more aggressive cancer. And so that treatment is very different than someone that would say get diagnosed with a very early stage, which is something that we would call like ductal carcinoma in situ. That's a very early stage. That's actually a stage 0. It's the very earliest that you can get it. So those treatments are very different. So I do think that as the technology increases, that we'll be able to see some different treatments. They're already coming out. There's studies. We have national guidelines, and those are based off clinical trials. And those guidelines change almost monthly. They are updated monthly and provide all physicians with guidance on what to treat.
In my cancer, because I was negative to all 3 of the hormones, they consider it environmental. So of course I was like, oh my gosh, I'm never going to be able to use perfume or deodorant or wash again, because they say it's environmental. But actually the top 3 causes of environmental cancer are secondhand smoke, obesity, and lack of exercise, that like Leslie had talked about before.
And that was actually my final question was, do you think they would find different ways besides using chemo to treat cancers?
Well, chemo is one of your primary ways of treatment. And so We can reduce our risk. We went through kind of all those things that are increased our risk. So we can reduce our risk by eating healthy. You want, low fat, high fiber diets. You want to get out and do moderate exercise. Even 30 minutes for 5 days a week can help lower your risk. Limit your alcohol consumption to just occasional. Stop smoking. All this can reduce your risk. But as far as treatment goes, your two primary treatments are what we call radiation and chemotherapy. So the difference between the two is chemotherapy gets you from head to toe, and radiation is kind of like a flashlight beam. It's like you're getting an x-ray. You do not feel it whatsoever, but it's just treating the particular area. It is literally like shining a flashlight beam. So it's just treating the breast. Not everyone gets radiation. Not everyone gets chemotherapy. That's when, after that pathologist kind of comes up and gives you a stage and a grade for it, based off that is what they determine which one you get. Some people get both of them. But I don't foresee chemotherapy being one that will stop because it is one of the primary treatments that we use. Good questions, though. Great questions.
Okay, Abby has a question.
Okay, Abby.
So you pretty much answered my question on like how you detect it and then find out whether or not you have it. What is like the differences between stages with like breast cancer?
Good question. Good question. So the best way to start off is to kind of talk about the breast itself, just the anatomy itself. So the breast tissue is made up just of kind of fat and this connective tissue. When women go and we talk about doing breast self-exams, a lot of women get concerned because they're just kind of these lumpy, bumpy kind of breasts, so to speak. That's normal, though. That's actually normal. And most breast cancers do not have any pain with it. You can feel these lumps that kind of change monthly. Those are kind of normal. So you want to go, when you're doing those exams, if you feel anything normal, anything abnormal, you want to write it down and make sure that you're comparing it to the next month so you can see, because like I say, some of those kind of come and go. So staging, we base that off of, you have these ducts throughout your whole breast, kind of like a little branch, and at the end of them, you have these little things like little flowers called lobules. The milk is created in those lobules. They travel through the duct and out the nipple. When the pathologist is giving what particular kind of cancer you are, he's going to give a few words. He's going to say one, where it's at. His carcinoma is going to be the word. And right in front of it, it's going to either be ductal or lobular. That lets us know if it's in that little lobule, which is where the milk's made, or if it's actually in the duct where it's traveling through. The ductal carcinoma, the ductal cancer, is the one that's that we see the most. The other thing we see is we call it, it's either in situ or it's invasive. So if you imagine like a scope that you're just cut in half, and when you're looking down, so the cell in it, if all the cancer cells are just in that duct and they haven't got smart enough to kind of start coming out of that duct, that's what we call in situ. If they start kind of going out of that, then it becomes invasive, and that increases your risk of it advancing and spreading to other places. So stage 0 is considered that in situ, means the cancer cells are there, they're just not smart enough yet to kind of start invading around the tissue. As it goes on, you go up to stage 4. Stage 4 means that not only we look at the size of it, which determines kind of those stages, but we also look to see if it's in the lymph nodes. So the lymph nodes drain, you've got them throughout your whole body. And a particular lymph node for your breast is called a sentinel node. That's what drains the breast. If it's in the cancer is found in the lymph nodes, that advances it down up to stage 4. Now, you can have it in your lymph nodes and it be under a certain nowhere else, no indication of it being anywhere else in your body, and be a stage 2 or 3. We look at the size of it, the size of the tumor, if there's lymph nodes, and if it's anywhere else in your body. That's the three main things that we look at. If it is in other places of your body, then that's what we would consider a stage 4. At that point, we can't cure it, but we can definitely treat it. But it just changes kind of the verbiage a little bit as far as instead of being cured to just treating it. So does that kind of answer your question? Okay.
And we've got Michelle.
Hi, Michelle.
Hi. So my question is, we talk about early detection and stuff. Why is mammogram set to a certain age?
Great question. So mammograms, so typically the ages that you see are women that are over 40. Usually, actually, you know, women in their 40s to 60s are the age group that's diagnosed the earliest, except with those if you have a considered high risk where you have that family member that is a close relative, that first degree, or if you carry that gene, then that changes a little bit. The recommendations, though, are at age 40, and you know, I don't know if you knew, well, a few years ago they tried to kind of change those recommendations, and I was sitting here pulling out my hair because you know we're seeing women in their 30s coming in with it, and I'm like, don't push it back, so based on the age of the time people are diagnosed, that's the reason they kind of start at 40. But if you are high risk, then what they'll do is they'll start you earlier. And they'll look at the ages of the people in your family, what time they were diagnosed, and they'll do what we call just a baseline, and then they go off of that. So good questions, good questions.
Actually, I have a question myself. I know you spoke about preventative measures to help you avoid breast cancer, but for those who are at high risk or they carry the gene, could you talk a little bit about mastectomies, for and against them, or any other preventative measures that are more definitive than just losing weight and stopping drinking alcohol and smoking?
Perfect, great. So if you are a patient who has come back and you've tested positive for that gene mutation, that means it is a hereditary component. What most of the physicians do at that point, and like I say, if you inherit that gene, you have a 56 to 87% risk of developing breast cancer by the age of 70. Most women say, or men say, I don't want to take that risk. So a lot of times what they'll do, and it becomes an individual choice, but they will recommend, if you carry the gene, they will recommend a double mastectomy. So the treatment of choice now for most breast cancers are what we call lumpectomy. So a lumpectomy is where they go in and they just remove that area where the cancer is and a little bit of tissue around it, but you get to keep your breast. A mastectomy is where they go in and actually remove the whole breast. The reason people say, why don't they just take, you know, the whole breast off for every patient who's diagnosed? I'll tell you why. So we do all these, you hear us talk about all these clinical studies we do. Well, they did a study and they had women who they removed just the lump, had them in one group. They had another group who had the lump and radiation afterwards, and then had a group of women who they did the mastectomy, removed the whole breast. When they looked at the chances of it coming back, the women who just had the lump removed stood a much higher chance of it coming back. So they said, forget that. So when they compared the women who had the mastectomy versus the women who just had the lump removed and radiation, the chances of it coming back were about the same. Because although you're getting the breast tissue removed, there is still some tissue that's left there. So it can come back actually in that scar, in that chest wall. A lot of people don't realize that, but it does. You have a small chance of it coming back, but it does. And then we treat it at that point. So most women, if they have test positive for the BRCA, they do go in there and they'll opt for the double mastectomy. And in addition, because if you carry the BRCA gene, you also are at risk of developing ovarian cancer. So because of that, they'll go in there and they'll recommend for them to have a hysterectomy as well. So great questions.
Another question. because I know that mental health is as important and as much of an impact on physical health as treatments and chemo, what kind of mental health treatments do you recommend, and does Albemarle provide support groups, therapists, and things of that nature?
Great, good question. So I'm gonna answer part of that, and then I'm gonna let Karen answer part of that from an actual patient standpoint, that she can kind of explain to you what she went through. So we do a lot of evaluating on the patient's mental status because it's just overwhelming. I mean, they're put in this journey. Everything in their whole life is just flipped upside down, and it just has them reevaluate everything. So there are these distress tools that we go through with them at multiple times throughout each doctor's appointment, and based off of that is what we can kind of do as far as referring. So the hospital, we provide a few things. We are currently working, we used to have a support group that we held right here, actually at the cancer center, but we don't currently have that going. We're working on starting up another one. However, with COVID, things have just kind of been a little crazy. We've not been able to meet. Centera does offer virtual support groups, so you are able to do that, similar to kind of what we're doing right now. You're able to do that. And we do have therapists around here in the event that someone wants to go talk to someone professionally. Part of that role is my role as well. They can call me. A lot of times I have spent hours on the phone, just talking with people, and kind of just sometimes, like I say, they just simply need someone to listen and just kind of walk them through. The thing is that I tell patients there is no right way nor a wrong way to go through this. Everyone's different. Everyone's going to experience it different. They're going to have days where they feel great, like, hey, I got this. Then they're going to have days where they're sad. They don't think that they're going to. And then there's days that they're angry. They're very angry and they want to bite the person's head off that's sitting with them. In the event that those days, I tell them, I'm like, hey, that's fine. You have the right to feel any of those. If it's one of those days that you are angry, I said, just let your loved ones and your friends know, hey, it's one of those days. So, give me a little bit of space. Or if I do bite your head off, no, don't take it personally. So, I mean, kind of what did you experience through that?
When I found out that when Dr. Ruiz called me and he said, Karen, yes, it is cancer, I kind of already knew that it was. Even though I already knew it was, it like to knock me off my feet. I was here at work. I have big faith, and I'm also one that just takes a deep breath and gets up and goes to what I have to do, go forward to what I have to do. And one of the first things I did was, of course, went to Leslie and said, Leslie, look, this is what's happening to me. So Leslie went over every test I had, any question I had. She was always right there to answer it immediately. And I wasn't like having to wait for the doctor's office to call me back. We had the Living Beyond Cancer classes that we did every quarter here, which was a big help for me because I felt like I was being able to give back to a community that has supported me during, my bout with cancer. And it talked about, the physical activities and the how you eat and what different diagnoses mean, and, just all kinds of other people asking different questions that you didn't think to answer. And it also gives you a little bit of a support group to know that you're not the only one there, going through that and having the only one to be there. And to, my work environment was very supportive of me. I never wore a wig. I walked around here as bald as a cucumber.
She's beautiful.
Oh yeah. I even think Bailey might even remember that. But anyway, yeah. But I felt like cancer was not something that I was going to let define who I was. So that's the biggest thing that I can say to anybody out there is don't let it define who you are. You know what? It's a bump in our road. We And you know what? You just do one thing at a time. That's what Leslie kept saying to me. And I'd be going, but Leslie, am I going to live 5 years? But Leslie, am I going to do this? And she'd say, well, the first thing we need to do is have your mastectomy. You know, the second thing we have to do is go through your chemo. So you want to, you know, not take on everything at the same time, you know, and do. But we have also, but Leslie didn't mention, is we had started the Unique Boutique, which is a boutique for women, men, whoever, that would be supplied with lots of information on lots of different cancers. And also we had a generous donation of someone, and we were able to purchase like 200 new wigs. And these would all be free to the community out there for women that needed to have a wig, whether they needed to have one or they needed to have 5. And it was all free to them. And it was someplace that they could come and kind of let go privately and, you know, try on wigs and things. But of course, COVID hit, and so we haven't been able to open that yet. But as soon as we can get the go ahead to do that, we will be offering that again. And again, like I said, my biggest thing is to be able to give back, is to be able to help other women, men, and it doesn't matter what kind of cancer you have or did have. Cancer is cancer, whether it's your pinky toe or, you know, your earlobe. Cancer is cancer. So like I said, we just don't want it to define us, and we want to help other people not be defined by it also.
I would like to add that, you know, she brought up about, you know, the donations that we have and being able to provide certain services. So our breast center here is actually called the Zach Owens Comprehensive Breast Center, which has been accredited by American College of Radiology as a center of excellence. We offer mammograms day and evening, Monday through Friday, and also offer Saturday appointments as well. But you do not have to have a doctor's appointment to get that scheduled. You can go in and you can call and schedule it and just say you don't have a physician. That's perfectly fine. Or you can go online at Sentara.com and do it. But a lot of women are concerned with the financial aspect. The EMS annually does, they sell shirts for October for breast cancer awareness. That money that they raise, they donate it to the breast center, and that money is used to help pay for the cost of mammograms for those that are not able to pay for it. So just wanted to throw that out there at you.
And our volunteers here at the hospital through our gift shop and different fundraisers that we have also participate in donating to the breast center to help women that don't have it, or for them to get equipment or things that they need to help.
Okay, Michelle has another question.
So my question is kind of for both of y'all, because I feel like both of y'all could give a very unique perspective. As a survivor, is there a specific obstacle that you face that you would like to bring awareness to for other survivors? And kind of on the flip side, as the coordinator, is there one that kind of obstacle that sticks out that you like to try and make sure that each person handles?
For me, I think the biggest obstacle that I come through is I'll be going along, not having the best day or whatever, or the best week or 2 weeks, and then all of a sudden it like hits me like a brick wall that, oh, I had breast cancer, and oh, it was aggressive, and oh, is it going to come back, and oh, is that pain in my shoulder, do I have bone cancer now? And I think that I would tell you that, and I would tell other survivors too, absolutely pay attention, and absolutely, but absolutely it is normal to do that. I have gone to Leslie with those questions, I know 100 million times, and never has she said, I told you last time that, but what I want to say is it's really, I think, in other survivors that I have talked to, I think that that's one of the things that happens to us is in the beginning, that's all, for example, in the beginning, it's all you think about is you're going to go to this doctor, and then you have this doctor's appointment and this doctor's appointment. Well, when I went to my oncologist the last time, he said, well, I'll see you in 6 months. And I went, wait, what? 6 months? I said, are you trying to break up with me? Because I've been seeing this man like forever. And I'm like, I don't know, can I do it without you? And he's going, you'll be fine. You'll be fine. But I think that's one of the things is just to know that, you know, this is not something that you're going to do and forget about for the rest of your life. And it is okay. And it is okay for you to think about it. It is okay for you to cry about it. And it is okay for you to ask a million questions, because it is your health. You know your body better than anybody else. And you need to be the advocate for yourself, because you don't want something that everybody else says, oh, is nothing, to turn out to be something. But everybody grieves the cancer process in a different way. So I would say, you know, like I said, we just get out there going on our way, and then that brick wall hits you and you're just kind of taken aback for a little bit.
Yeah. And so the two main obstacles that I typically see is, you know, it's no secret that, you know, medical treatment can be very costly. Particularly cancer treatment is very expensive. And a lot of women, when they come in and start their treatments, they're overwhelmed by that. And I repeatedly tell them, do not let the financial aspect of it prevent you from getting treatment. There are a number of sources out there that we can use to get to, you know, work with that. Centera has a financial assistance. There are a number of state assistance. A lot of the pharmaceutical companies have programs for the chemotherapy that they can help. So by all means, I never want a patient to not seek treatment because of a financial concern. The other thing is similar to what Karen said about everyone grieves the process differently. I see that a lot. And a lot of women will come in and say, you know, they've talked to their friend and this patient, this, you know, their Aunt Sally had it, and, you know, this is how they did. It doesn't matter how someone else handled it. It only matters how that particular patient handles it. And there again, there is no right or wrong way. Everyone goes through it differently. And I don't ever want a patient to feel like that they're having to, so to speak, put on kind of a face of, you know, this is how I'm feeling, or this is how I should respond. I don't ever want them to feel like that they are alone. So a lot of the conversations we have sometimes are simply them just venting and honestly saying kind of how they feel. And you know, like Karen said, you know, there's days where you start worrying about every test, and, you know, well, what if this happens? What if this happens? You can't think that far ahead. You can't think that far ahead. You take, you know, every day for what it is. There actually is, you know, we talk about a lot of things about what cancer can do. And I actually have in my office, you can't see it, but it's a poem up here that says what cancer cannot do. And then it goes through all the things that cancer cannot do. And we have to be reminded about that. You know, they cannot break friendships. You know, it cannot, you know, corrode your faith. You know, a lot of women that we see, a lot of patients, regardless of what cancer come in, have a very strong faith, you know, and they use that and their support system for that. It cannot break that. And that's a lot of things that we have to remind patients that, you know, cancer can, yes, it can do a lot of things, but there's a lot of things that it cannot do. So,
and to add on to that, kind of one of the things that I would say to you, if you happen to know someone who is going through that process or just finding out, or for you yourself, if you ever go through that, absolutely do not go to Dr. Google.
yeah,
Googling is the worst thing you can do.
I will come home to do that.
Yes, it is. You get out there, and Dr. Google has answers, but it's a generalization. It's not your specific case or your specific thing. And of course, the first thing I did when I got home that night was I went right on to Dr. Google. And it was the worst thing I ever did, scared me to death. I was in here just falling apart, telling Leslie, oh my gosh, this is what's going to happen. This is what it says. I'm not going to, you know, do so. Do not go research. Don't research unless your doctor or your patient navigator gives you where you can go and look. But don't just go to generalities, because it is just that. It's general. It's not your specific case.
Colleen has a question.
Okay, so you hear a lot of commercials on television about metastatic breast cancer, and I know that that means it's spread to other parts, but when you were talking about all the different levels, are there more? Is there one type or another that tends to be something that usually spreads to other parts of the body?
Good question. So typically you're that early stage, that DCIS, where it's just kind of localized in that duct and it hasn't started spreading in the breast, those typically do not. If you catch those very early, those don't. Then you can have what we call invasive breast cancer, which is they're smart enough, they've started coming out of that duct, but that doesn't mean it's spread anywhere. That's stages 2 and 3, and that's based off kind of the size. When you have it that has gone into your lymph node, then you stand the risk of it going somewhere else. Now you can have it in the lymph nodes and the scan does not show anywhere. This is going to kind of explain why it's important when you get chemotherapy, because if it's in your lymph node, means it has increased risk that it's gone to other organs. However, it takes lots of times 1 billion cells to show up on a scan. So it could be those cancer cells could be floating around in your body and you're not aware of it, and you have your scans are completely negative. That's the reason we go in there if you have positive lymph nodes and we give you chemotherapy, because the purpose is to go in and try to kill any cancer cells that are there. Once it is that stage 4, that metastatic. The most aggressive one is typically, from all the studies, is the invasive ductal carcinoma with those 3 negative hormones. That's been proven to be the most aggressive one thus far. Yeah,
It's me. It's me.
but Karen is doing wonderful. I mean,
Yeah.
she's gone through, she's got her treatment, and all her scans and everything are looking great. So that's
Yeah,
the
yeah.
reason she went and got that chemotherapy, to go in and try to kill anything that was there that simply would not show up on the scan as of yet.
Yes, and they also thought that mine might have been, we all think of cancer as being a mass. Well, they actually felt that mine was what they called multifocal, which means that it's like somebody took a whole bunch of little dots and went fat, and so it was kind of all over. And so that was why mine was a little different too, than everything else. But I did not have any lymph node involvement. So that was the good thing. And I did choose to have both of my breasts removed, because it took my cancer rate down from like reoccurrence in the older breast would have been like 15%, and it brought me down to 2%. So that is why I chose to go ahead and have both. Yeah, so with that triple negative that we talk about, because we know that's an aggressive one, even if it does not show anything in the lymph nodes, the recommendation for those is a mastectomy, and you get your chemotherapy with it, even if it's not in the lymph nodes, just because we know that that is a more aggressive cancer.
Patrick has a question.
Hey, Patrick.
Is it Karen? Am I getting that right?
You're
y'all
not
need
gonna
to know.
ask me to marry you or anything, are you? Because I'm not prepared.
Karen and I are very dear friends. Karen, could you talk a little about your decision to go ahead and have reconstructive surgery and kind of what you went on? Because that was a big part of your journey.
Yeah. Actually, when I decided, we had decided to have the double mastectomy. Dr. Ruiz had paired me with a plastic surgeon, Dr. Gallardi, and they do surgeries together. So what was going to happen is that Dr. Ruiz was going to remove the breast, and then Dr. Gallardi was going to come in with the implants, the reconstruction, or the expanders, yeah. So, of course, when I first went to see Dr. Gallardi, I was like, I'm having them taken off. I don't want to do anything. And Dr. Gallardi explained, well, Karen, that's all fine, but if we take them off, there's going to be an indentation, which I never thought about. I just thought, like cut off and they were done. he said, so how about if I just give you a little, little bump, and we can kind of go from there. And I agreed, because I was having none of it. I was done. I was finished. I didn't want to have to worry about it. I didn't want to have to go through anything. And Dr. Gallardi, bless his heart, when we went back the second time, what they do is they put in expanders. And if nobody knows what an expander is, it's a little bag almost. It looks like a little vacuum cleaner bag with a big hole in the middle, but it's a what do they call them? Self-sealing holes. Self-sealing holes. So I would go in. So I went into Dr. Gallardi's office, and he says, okay, what have you decided? How do we want to go? He said, I think you might need to have a little, I think it'll make you feel better about yourself. And I said, okay, so I agreed to have what he would typically consider your fill-up. So they take and they fill the syringe full of saline. And then he takes what is called, my husband calls it a stud finder, but he finds that hole where it is in an expander, and then he fills that with the saline. And what that is doing is expanding the breast because you have skin over it. You just have skin, so it has to expand. And so with Dr. Gallardi's encouragement, thank goodness, I was able to get to a point where, I did want to look a little bit more like myself and things like that. And I was glad that he had been so patient and kind, but they put those expanders in. It sort of expands you to where you want to be. And then once you get to the size you want, they remove the expanders, and then that's when they put in the silicone implants. So it's a kind of a two-step thing, but I'm glad that I did it. I feel I'm glad that somebody just didn't go, okay, well, if you don't want to do anything, don't. I'm glad that Dr. Gallardi took the time to know who I was, to realize that that's probably what I needed. And I'm definitely very glad that I had the reconstruction. And like I said, they did it right about the same time. So, there wasn't like have the mastectomy, then go back, and then go back. It was, you had the mastectomy, you got started on the reconstructive road, and you were there. And you did the reconstruction and the chemo about the same time. Your fill-ups and the chemo were like, we did one every other week. So, but I'm happily glad I did.
Yeah, the surgeons in Elizabeth City are great, regardless of which office you go to, whether the Centera, Carolina Surgical, they're both really good.
Mm-hmm.
That once so if you have a biopsy done, then you typically come back, it's done in our breast center, you come back a week later, you meet with myself and the radiologist, and then we schedule you an appointment, a consult with the surgeon. At that point, you go to them, they kind of talk from a surgical standpoint. But before they go in and actually do any surgery, they will send you to the two different oncologists, a medical oncologist, which is the chemotherapy doctor, and a radiation oncologist for radiation. And you go meet with them and you're consulting with them. They'll provide you information. So you have all of that before you decide on what surgery you want to do, which I think is really good.
Yeah. And we do have very good surgeons here that I've actually had a couple of friends who have unfortunately had breast cancer, and Dr. Rogers has been wonderful. So, right here in our own hometown, we've got surgeons who can perform that and do a great job.
Dawn has a question.
Going back to, you were talking about T-shirts for raising money. Is there a way that you could please email me that information of who I need to notify about purchasing some T-shirts, please?
Sure. I'm not for sure. They usually do it in the month of October. I'm not for sure how many they have left because I think that they sold out pretty quickly, but absolutely, I will email you that information. So,
thank you.
Yeah.
Does anyone else have any questions?
I have a question, promise.
Okay.
I know when someone is diagnosed, the focus tends to go on the patient, as it should, but what can friends and family, what can we do or they do to help support the patient? Because I know sometimes people of strong faith, they'll be like, God's not going to let you die from this, or that's not going to happen. And it sort of prevents the person from coming to terms with the possibility of it and voicing their fears because they don't want to sadden their family and their friends, their kids and their spouses. So what can they do to support the patient in any way?
Great question. So let me address that a little bit. So when I meet with patients, I'm a Christian. I'm a believer in God, and so very quickly I am kind of evaluating what the patient's what their faith is, what their beliefs are, and if there is any indication, I'll ask them, would they like for me to pray with them, and then we get in that conversation. And you're absolutely right. People, that do have faith, they'll say, well, God isn't going to, he's going to heal this. We have to remember that healing comes in a variety of ways. And healing may not be taking that cancer away. And so I actually have that conversation with patients about what healing means. As far as the family goes, families are just as important. Their caregivers are just as important as the patient, because they're walking this journey with them. It's in a different aspect, but they are taking every step of the way with them. The biggest thing that they can do is know that sometimes they just their presence for the patient, just being there. They can, if they're having side effects, of course, you can help them with that and talk to them. But a lot of times just being there and letting them know that you're there is a huge thing to do, especially being aware that they are going to have an array of emotions and their days will not be the same. And just knowing that and kind of accepting that will be a huge relief for them.
Yeah, I know on my end, I know that a lot of people, of course, paid attention to me because I was the person with cancer and this is going on. And what Leslie said about healing is true. You have to realize that healing does come in a lot of different forms, and it may not be like right now, even though I'm healed, I have neuropathy in my hands and in my feet, like I can't feel them. And that's been I have had 2 years of that. So is that complete healing? I don't know, but I'm still here to talk about it. Does that mean in 2 years things won't be different? I don't know. But as far as for my husband, as for him being my caregiver, he is a lot the same way. If he's thinking about it or I'm thinking about it, we try to talk about it. Our fears. Do I want to think that, oh my gosh, I may not live to be 65? No, I don't. But you just can't always think about it, but you might have to talk about it. What happens if I'm not here? What are you going to do if I'm not here? Or, just what if something happens and, my neuropathy is worse and brings on something else? What if that brings on heart issues? So, you have to remember that you've had cancer, but I could leave here tonight and get hit by a bus. So you just kind of gotta wave through it. But as far as the caregivers, they need time off. They need to be able to sit and cry in a corner. They need somebody to take them out to dinner or to a movie or just walk down the street, just so that they can get away from a little bit from the total situation, because they're in that total situation. You're going through it, but not like they are, because they're trying to control your environment. So they need help from the outside to help them help control the environment. So any little thing you do for them, a card in the mail to the caregiver or to whoever's taking care of them or what they're doing. Or like I said, send them, send them a gift certificate for Panera or something, or call them just out of the blue to go to lunch, or, hey, let's go to the beach for the weekend. Anything like that you can do. And most of the time they are so appreciative of that. so appreciative of it. So, we have to remember that the person going through it is going through it, and we kind of know what we're doing. But that caregiver is just trying to control everything because they don't have, that's what they do. That's what they do. So.
And there's support groups for the
Yes.
caregivers as well. And we encourage them to attend those, as well as the survivorship classes that we provide. We tell the patients, and caregivers, it's open to anyone.
Yes.
So.
Do we have any more questions? Well, I want to thank both of you very much for coming up here. This is something very important to me and towards my family. So I appreciate you taking the time to come up here and talk with all of us. And I'm so happy you're here with us because you're a great person. I've heard great things.
Nuts.
Took on the spot. He said, that both of you ladies are so amazing that he knows you both personally. So again, I'm so glad that you're here, and I, faith is big. My mother had brain cancer when I was 7, and she's still here with us.
Oh,
No,
my
yes,
goodness.
that's
Yes,
great.
that is,
Yes.
Yes, ma'am.
That's not an easy one. That's not an easy one.
No, ma'am. She lost her sight and she lost her hearing. She got it all back, but we're good. But again, thank you again. If you can send me that information for the shirts, we would love to support any way we can.
absolutely.
COA is big here with the community. So anything that we can do, please reach out to me and let me know what we can do to help out, especially with our SGA Executive Board. We have ambassadors, which are our students. We have our NSLS Executive Board, which are they're all students. So, and they love to get out in the community and help as much as they can with anything. So again, I want to thank all of you for being here on our 3rd Dolphin Podchat. Our next one will be November 3rd on Tuesday. So if no one else has any more questions, thank you again, and everyone have a great day and be safe.
Thank you.
Bye.
Thank you.